There are two peptic ulcer diseases. They're called peptic because these are ulcerations caused and exacerbated by stomach acids, including pepsin. They are gastric or duodenal. Very rarely, patients can also have esophageal ulcers. That's also peptic ulcer. But two most common types are either gastric or duodenal. This is what it will look like. So what's protecting our GI tract from our own stomach acids? What will protect it? Because there's acids everywhere in the GI tract. So what will keep that acid from damaging our intestinal organs? Because these acids can dissolve anything, right? So what will protect it? What do you call that lining? Yes. Okay, there's a mucosal barrier. So a thick layer of mucus is constantly produced by cells in the surface of the epithelium of the GI tract. And as long as that mucosal barrier is intact, meaning the cells continuously produce it, the GI tract is protected from the acid. So therefore, what will cause peptic ulcers? Okay. Risk factors. There are two most common causes. There are many, including stress, NSAID use, meaning chronic NSAID use, as well as H. pylori infections. H there stands for Helicobacter pylori. This organism is picked up at some point in our lives, from the soil, entered our mouth into the GI tract. It lives there and just waits for an opportunity to cause an infection. In the past, stress and anxiety were thought to be the cause of peptic ulcers, but what does it say? The first phrase says in the past. Okay, so now we've learned what actually causes peptic ulcers. H. pylori and or chronic NSAID use. So which people will be taking ibuprofen on a regular basis, like multiple times a day for months and years at a time? What is ibuprofen for? It's a pain medication. Yeah. So who will be taking these? IV drug users? Who take these? Tell me who? Who are they? See people with pain. Most commonly. So you gave rheumatoid arthritis patients, yeah? Okay. So lupus patients, right? So people with chronic pain will be taking ibuprofen. Now, osteoarthritis as well. Okay, osteoarthritis, rheumatoid arthritis. These patients have pain. No other pain reliever will work best with those disorders except NSAIDs. So can you tell them, therefore, stop taking NSAIDs and just suck it up with the pain? Because the NSAIDs will cause peptic ulcers. So what do? Patients are complaining of pain. Only NSAIDs work. Okay? You can't tell them to take opioids. Okay? Opioids would be inappropriate for those chronic types of joint pain. Okay, because anti-inflammatory analgesics would work best for those, and that's what's recommended by physicians as well. So how do we protect them from?
It seems like a supplement, like I know milk produces a lot of mucus.
Milk will not work. What else? Well, any other ideas?
Like a supplement to produce mucus, right?
So in the first place, the answer is, what is the action of ibuprofen and aspirin? How do they work exactly? How do they relieve pain? How exactly? How do they work? So if you read the drug book, what is the action of ibuprofen? They inhibit what? They inhibit prostaglandin. Okay, so what is prostaglandin? Okay, there are many types of prostaglandins. There's prostaglandin P, there's prostaglandin E. All prostaglandins, though, are vasodilators. They are responsible for ensuring that blood flow to microscopic cells, including the cells that produce mucus in the GI tract, maintain blood flow. Okay, so we need prostaglandin, don't we? Yes, unfortunately, prostaglandin is also a pain neurotransmitter. So therefore, if you inhibit prostaglandin, will pain be transmitted? No. So that's how it relieves pain. Unfortunately, again, it inhibits microscopic or capillary vasodilation. So therefore, it will do the opposite, which is now vasoconstriction. So what happens to the blood flow to those microscopic cells producing the mucus? Decreases. So what happens to those poor cells? They die. Can they produce mucus? No. So therefore, that's how it works. That's how NSAIDs damage the mucosal lining, because now there's no more mucus, or there's not enough mucus. So now is our GI lining exposed to acid now? Yes, and then that's how ulcers form. Any questions about how NSAIDs cause this problem? All right. H. pylori, on the other hand. So how does this bacteria cause peptic ulcers? Now, if you were an organism and I put you, let's say you're a bacterium, Benjamin, imagine you're a type of bacterium, and I put you in the stomach. Imagine the environment in the stomach. If you were inside this organ, how does it feel to be in there? Imagine you're in the stomach, somebody eats 3-4 times a day, and what will be produced every time you eat to digest it? Acid. Okay, so is it a wonderful place? You've vomited once or twice before, right? How does that taste? And then imagine you're bathing in that environment, you're swimming in there. So what can I say about that bacterium if Benjamin survives in that type of environment? So what can you say? How do you describe Benjamin? A badass organism, right? I mean, for you to survive in that environment, you have to be really badass, right? So therefore, these organisms burrow into of course, they're just not gonna bathe in the acid. Okay, so they will burrow into the mucosal lining. And by burrowing, of course, that they now cause a cavity, and then the ulceration is now exposed to acid. Then we have peptic ulcers. Okay, so two different causes, two different rationales on how they cause the peptic ulcer. And so therefore, since you describe Benjamin as a badass bacteria, how many antibiotics do you think we will need to treat him, to kill him? Just one? There will be multiple antibiotics to kill something like that. Okay, because if they can survive that environment, you think they can withstand one antibiotic easily. Okay, all right. We'll describe treatment later.
When you said borrow, what do you mean? Like they hide in that, or they create a hole?
What is burrow?
Borrow, I mean, like I have two definitions for it. Maybe one is borrow money from you, or
The spelling is BURROW.
oh, okay, that's the one that I'm thinking about.
Okay. So they're not the same. There's only one definition. They changed the spelling. Yes, that's a different definition. Okay, let's go now to manifestations. I explained the pathophysiology. Let's go to. So how do we know you have peptic ulcers? So most common complaint is pain, a dull, gnawing type or burning sensation in the mid-epigastrium or the back. This can also be mistaken for a cardiac event, meaning some people will mistake it as chest pain, chest discomfort, and they may be evaluated for acute coronary syndrome as a result. So the pain here, because we have two types of ulcers, one is gastric, one is duodenal, how do we tell them apart? Because both will report this type of pain. So how do we distinguish whether the patient has a gastric versus a duodenal ulcer? One difference is the characteristic of the pain, when the pain starts. Thank you for reading.
Most commonly occur immediately after eating. Rarely the pain associated with the juvenile that most commonly occur 2 to 3 hours after.
Okay, so where is the stomach? You know where the stomach is. Where is the duodenum?
Right before the stomach.
Before?
The stomach.
Meaning my duodenum is here? This is before the stomach.
It's after the stomach, in the back.
Okay, yeah.
Okay, so that's the first part of the small intestine. Okay. So how come the pain pattern is like this? Why is a gastric ulcer pain occurring immediately after eating, whereas if it's duodenal, the pain doesn't come until 2 to 3 hours after eating? So if it's a gastric ulcer, the ulcer is where? In the stomach. Okay, so what happens when you swallow something?
It's in
Sometimes
the
it's
stomach.
after the stomach.
It will not
Okay,
burn.
so else ulcers will, acids will start being produced, right? The moment you swallow something, doesn't matter what you swallow, whether it's water or coffee or even your own saliva. Okay, the moment something enters the stomach, what is the automatic response?
Mm.
Acid production. Okay, so therefore, does it make sense that when you start eating, the pain in a gastric ulcer immediately starts?
Yes.
Why?
Because of the stomach.
Okay, because the stomach where the ulcer is found is now exposed to the acid, thereby causing pain. And why is the pain, therefore, in a duodenal ulcer occurring later, 2 to 3 hours after a meal? So when we eat, what happens to the food? Does it go into the duodenum? No. The stomach holds on to the food for 2 to 3 hours. What's it doing there? Okay, whatever you are eating, chicharrones, tacos, carnitos, whatever you're eating is turned into liquid, right, in the stomach. That way, when it's all liquefied, then it enters the duodenum 2 to 3 hours later. Then the pain starts. Here's another characteristic. Because food is an antacid, patients with not duodenal ulcers actually likely to express relief of pain after eating or after taking an antacid. Okay, because food acts like an antacid, actually. These are other symptoms that may accompany the pain. Patient may have vomiting, constipation, diarrhea, or even bleeding, especially if the blood vessels are already exposed in the surface of the ulcer. Let's go now to management. Before that, patients with peptic ulcers are at risk for GI bleeding, and which is manifested by vomiting blood or pooping black stools. Once the patient is bleeding, meaning they have a bleeding ulcer, then they will report these manifestations. And then we finished already hypovolemic shock. So can this type of bleeding lead to hypovolemic shock?
Yes.
Yeah. Findings, we have to see the ulcer. There's really no blood tests to diagnose the ulcer. So we need what procedure will this be for to enable us to see a gastric or duodenal ulcer? Endoscopy. What is our patient preparation for endoscopy? For how long? For how long?
8 to 12 hours.
Okay, so about 6 to 8 hours. Okay, so usually it's early in the morning. So there'll be NPO after midnight. However, that's not always going to be going as scheduled. So let's say, yes, the doctor would schedule it at 7 a.m., sometimes 6 a.m. However, things happen, right? In procedure areas. So they get maybe an emergency. So this patient may be pushed back later. So just advocate for the patient because sometimes, let's say, I had one patient who was supposed to be scheduled at 7 a.m. So before I left for the day, I should have sent the patient already to the endoscopy. They usually pick the patient up around 6:30, and then they go to endoscopy even before I leave for the morning. This patient did not go until I came back the following night at 7:30. So the whole entire day, the patient has been NPO. Then I asked the nurse, so poor patient's now very upset. Obviously, how would you feel if not eating the whole day? And so what would you have done? Because the nurse didn't do anything. The nurse kept the patient NPO the whole entire day, since midnight and all day. So what should you have done? Can we feed the patient?
No.
If we feed the patient, then can they do the procedure?
You call the department, I asked them to do that.
Does the patient need the procedure to be done?
Yes.
Correct. Okay, so what does your judgment tell you? What would be the best course of action?
Well, that's what we- and follow-
The patient stay
see how long-
NPO for
How
1 week.
does that help the current problem? Patient is upset, they're hungry, starving. I would be too. You would be too. So what would be the best approach?
The best approach-
How would you advocate for the patient?
We schedule endoscopy. You wanna notify
Things happen. Okay, that's out of the control of the endoscopy staff and the doctor. Things happen during the day. But what do you have control over?
no.
Rescheduling?
You don't
Well,
have
then
control.
the patient will have to wait another and then do the NPO status all over again. They already suffered for a total of 19 hours already. So what would be the best course of action?
Is to
Can
notify-
you maybe ask the doctor for IV fluids?
Yeah, to hydrate the patient.
Yes, you could do that. You could ask, hey, the patient, and then just tell the doctor, whoever's in charge, whoever's the resident. Unfortunately, things happened at endoscopy, one after another. They could not take the patient until later tonight. Can we give the patient something? Okay, because we can give dextrose solutions, correct? Okay, so when you get those types of IV fluids, do they have glucose in it? Yes. So because what will make you hangry when your blood sugar is low? Correct? Yeah, anybody who's hungry would be upset, okay, angry, right? So that would be one way to handle it. So patient goes to endoscopy, we have to see the ulcer, and then the doctor will have to get a biopsy, make a little bit of tissue sample of the ulcer to check if it is positive for H. pylori. Because what are the two most common causes? NSAID use and or H. pylori infection. So if it's H. pylori infection, then what would be the course of treatment? Antibiotics. We'll get to that shortly. What if it's NSAID use, meaning the biopsy is negative for H. pylori? Then, okay, we'll get to the management for that as well. If there's any bleeding found during the endoscopy session, then the doctor will all go ahead and treat the bleeding. They'll cauterize the bleeding vessels. Okay. Okay, so the medical management depends. What is the identified cause? So if it's H. pylori positive, then 2 antibiotics plus a PPI will have to be given. We call that triple therapy. Some doctors will also use quadruple therapy. We have specifics shortly. So we have to treat the H. pylori. What is Benjamin again? Benjamin is H. pylori. How do we describe Benjamin? Badass. Okay, so we need several, we have 2 antibiotics. So most commonly used combination is 2 antibiotics, a PPI. Bismuth salts may also be used. Bismuth meaning Pepto-Bismol. Okay. So treatment is 10 to 14 days. So if it's triple therapy, that means it's a combination of metronidazole or amoxicillin and clarithromycin. Now, that's 2 antibiotics, right? Because it's or metronidazole or amoxicillin and then clarithromycin. The third in the triple therapy is a PPI. So how does PPI help heal the ulcer? What do PPIs do? Okay, they decrease the acidity of the GI tract. Or like I said earlier, it could be quadruple therapy, meaning 4 drugs, 2 antibiotics, just like before, a PPI, and then the Pepto-Bismol. Okay. Currently, this is being developed, but we don't have a vaccine available yet. So the therapy can be a PPI, or it could also be a H2 receptor blocker, not both. Okay, it's only either one or the other. H2 blockers will be given twice a day. PPIs obviously only once a day. Here are your drug regimens. H2 receptor blockers, they all end in tidine. Cimetidine, famotidine, nizatidine. Ranitidine is gone. It's been linked to cancer, so that's now out of the market. So Zantac used to be ranitidine, right? Zantac is now famotidine. They still carry the Zantac name because it's popular, right? But they changed the formula. It's no longer ranitidine. So we have our PPIs. They all end in prazoles, right? Esomeprazole, lansoprazole, omeprazole, pantoprazole, rabiprazole. So these are once a day for 4 to 8 weeks, whereas your H2 receptor blockers usually twice a day, 6 to 8 weeks. That period of time, 6 to 8 weeks, basically about 8 weeks, 2 months, is enough to help heal the ulcer, okay? Giving it time to be exposed to less acid, allowing it to heal. For H. pylori, these are again, we already mentioned the combination antibiotics earlier. So for patients who have no H. pylori, and then we identified NSAID, chronic NSAID use as the cause, they will be given. What is misoprostol? It is a prostaglandin analog. So if you're taking NSAIDs, which are going to inhibit prostaglandin, you're going to give a prostaglandin analog, okay, to replace what it was being inhibited. Misoprostol is also used for um, abortion. It's an abortion pill. So therefore, what should you caution the patients when taking these drugs?
Is after abortion or before abortion?
No, it calls.
It's an abortion
Oh.
pill. So what will you tell the patient?
Oh, got
All
it.
right. Okay. So if they intend to get pregnant, then not to take this drug. Okay. Or which one is a priority for them? Suffer the ulcer and then get pregnant? Probably they'll postpone the pregnancy, right? Okay. So just treat the ulcer and then after that, then go ahead and get pregnant. So patient, your job would be to ensure the patient complies with the therapy. I'm sure they will, okay, unless the patient really has other competing reasons not to complete therapy. But most people do because of the pain that they experience for several weeks. They want to get rid of that awful pain and then will complete the therapy. But you never know. Let's go now to, so here's your warning again about the misoprostol if the patient does take it. Oh, I forgot to mention why. So what is, oh, yeah, we already discussed, right? Okay, so this will replenish the prostaglandin, sorry. Smoking has been known to exacerbate the peptic ulcer pain because when you actually smoke, nicotine increases stomach acid production. So that's how it exacerbates the gastric or duodenal ulcers. Plus, not to mention, what is the effect of nicotine on blood vessels? They are vasoconstrictors, so therefore it will delay healing of the ulcer because now your mucus production will also be decreased. As far as dietary modification, there's really no diet that will heal the ulcer. All this paragraph means is the patient should avoid anything that exacerbates the pain. That's basically what this is saying. There's really no food that will heal the ulcer. However, there are plenty of foods that will exacerbate the pain, including alcohol, coffee, even decaf coffee, or add other caffeinated beverages. So your sports drinks there all have caffeine, so avoid them. But basically, avoid foods that cause you pain. That's the rule. In a hospitalized patients, the patients may be during the symptomatic period, meaning they're in extreme pain. There'll be either NPO or if the patient can tolerate foods, meaning the patient is tired of being hungry, they'll be given clear liquids. Or if they want, okay, I want to eat something, they'll be given a bland diet. A bland meaning no taste at all. Okay. So because if you what really triggers your saliva and your acids when you eat something nice, right? That has a taste. Because if you eat something that's not flavor, yeah, there's really no stimulation, right? You don't even want to eat it. Okay, so there you're given a bland diet. Someone before we used to think small frequent feedings can help, but evidence says not really necessary, has really no benefit with peptic ulcers. Again, so the conclusion is patient eat foods that you can tolerate, meaning doesn't cause pain, and avoids those that do cause pain. As simple as that. Surgery, we will skip. Surgery meaning we will just meaning the ulcer has already caused perforation, meaning your stomach or your duodenum has a perforation already, meaning there's a hole, okay, caused by the ulcer. So now whatever you eat will come out of that hole, right? Then we have fecal matter coming out of that hole. What could possibly go wrong? Okay, so therefore what will, well, peritonitis first and then sepsis, yeah? So what we'll do is remove it. Okay, so we either cut a portion of the stomach or remove the whole stomach altogether or the duodenum as well, whichever is the case. We'll skip these because we'll discuss pre and post-op, and that's really the same concept. Skip the surgical procedures. Now, for those patients who have peptic ulcers and chose or are not candidates for surgery, or for those surgery are not indicated, meaning this will be a chronic treatment, correct? Okay, so the maintenance medications are not under peptic ulcers, they're under gastritis because the treatment really is the same. So let's go here under medical management. So like I said, the medicines used to treat gastritis is the same as with peptic ulcers. So we know about the antibiotics. Here's the table 40-2. So the antibiotics were already mentioned on the next page under peptic ulcers. There's just one more drug here, and this was also mentioned, right? Bismuth or Pepto-Bismol. That was also in the quadruple therapy under peptic ulcer. And we mentioned the H2 receptor blockers also. And the PPIs. This last one was not, well, this one was also mentioned. So the last one is here, sucralfate. Sucralfate is given 4 times a day. So this would be before meals and also at bedtime. Instruction is before meals, 1 hour before meals, and then also at bedtime. So what is the purpose of this drug? It creates a viscous substance which will form a protective barrier binding to the surface of the ulcer, protecting it from the acid. Meaning if you take this 1 hour before, so this will stick to the surface of the ulcer, therefore protecting it from acids. So when you eat 1 hour later, then will the acid exacerbate the ulcer? No, because you already coated it. You already coated it with the sucralfate. And that's it. Any questions? Okay, let's go now to the complication of peptic ulcers, which is bleeding. So when the patient has acute GI bleeding, right here. So we discussed hypovolemic shock, which is caused by bleeding or hemorrhage. And what was our management again? What was the first thing we do for hypovolemic shock? We give blood or fluids first? Fluids or blood first? Fluids first, right? It's ABC, right? So circulation. So fluids first and then blood. Because do you have blood in the staff refrigerator? Oh, where's blood come from? Okay, so can you just get it there? Okay, it has to be processed, right? Okay, so in the meantime, you maintain perfusion by giving fluids. Okay, so we give a bolus of fluids, and then when the blood is ready, then we can administer blood. So usually when the patient is bleeding, let's say it's upper GI bleeding, what will eventually happen? Will the patient start vomiting? Yes. And what's the danger when you vomit nonstop? Or before that, ABC again, what will happen first? Aspiration, right? Okay, so a patient will aspirate. So we will have to insert a NG tube. What's the purpose of the NG tube? Is this for nutrition?
Yes.
So we're gonna feed someone who is bleeding. We're gonna put Glucerna in there. We're gonna put. So what is the NG tube here for?
It's for
Yes.
Distinguish between blood opening from the stomach or the duodenum.
it's to avoid blood clot.
No, so distinguish from blood from poultry grounds.
What's the purpose? It's patient's bleeding, so why do we need to distinguish? So why do we put an NG tube inside?
Because of the aspiration.
So Aiden
It's basically, like, it's for the GI tract, you give medication to the NG.
Oh.
Yeah, it's like-
Okay, well, we can also use it for, okay, actually to decompress the gastric contents, meaning rather than allowing the patient to vomit, which is dangerous, right? Because if your blood pressure is very low because you're bleeding and then you're vomiting, what could possibly go wrong? Are you still conscious? No, probably you go unconscious, and then what happens if an unconscious or semi-conscious patient vomits? Aspiration and death. Okay, so therefore it's better to suck those things out rather than causing vomiting. So rather than letting the patient vomit, because they will vomit, because where else will that blood go? Okay, because when you're in the, remember what happened? We talked about shock. What happened to the GI tract in shock? What happened to the kidneys? Will the kidneys make urine? No. Why? Because what was stimulated? Sympathetic nervous system, right? And renin-angiotensin-aldosterone system. So do you think there will be blood going to the GI tract and the kidneys? No, that's why the kidneys shut down, the patient becomes oliguric, right? And will there be any peristalsis? No, because blood flow is also cut off to the GI tract. Which three organs will only receive blood? Heart, lungs, and the brain. Okay, so everything else will be expendable. Okay, so we will not give blood flow there, so there is no peristalsis. So this patient will just keep vomiting because they can't come out the other end. It will just come out here. Okay, so we need to put in an NG tube, suck that out so the patient doesn't vomit. Yes.
Saying the D5 and the blood. You're giving both of them at the same time?
What do you mean D5?
You said, yeah, the dextrose. You said,
What dextrose?
when the patient is dehydrated because.
No, we discussed hypovolemic shock, so we use saline, right? Or LR. There's no dextrose.
Both of them going together, it is become piggy bank. How will you give it to the patient?
Oh, well, every hospital is different.
Say your question again.
I said, you said by the time the lab make the blood, we have to give the dextrose to the patient. So when the blood comes now,
Where did dextrose come from?
I think she's just saying, I think she means the fluids, the IV fluid.
Then don't say dextrose. Okay, dextrose is a specific fluid. So we discussed only in shock, it's saline or LR, right? Isotonic solutions. Yeah, crystalloids. Don't say dextrose. Dextrose is not a crystalloid. Okay,
Okay,
it's an
so-
isotonic. D5W is an isotonic, but it's not a crystalloid. Crystalloid are only saline and LR. So say your question again.
my question is like, when the blood comes now, what you have to do, you stop the like the ranges and then you start the blood or you give.
Really depends on the patient's blood pressure.
Oh,
Okay.
okay.
So because will the blood raise the blood pressure fast? If it's running at 120 ml per hour? No. So that would be my answer. Depends on the patient's blood pressure. If the MAP is still below 65, you think we will stop the fluids and then just give blood? No, patient will need both. So patient will be getting the IV fluids on one IV and then the blood on another. Okay, unless your vein is really big, because you think let's say you have a small vein here in your arm, right? And then you're running 1000 ml per hour of IV fluids and then blood at 120 ml per hour. You think that small vein can handle 1120 ml per hour? No, that you'll damage that vein. Okay, so therefore you'll probably need two. Okay, can probably handle 1000. Central lines, no problem. If this patient gets a central line, that's great. Okay, then you can flush, you can give everything through that central line. Okay, because it's a huge vessel. So it can handle anything. But if we're dealing with peripheral IVs, then you need multiple. Okay, so usually one dedicated for bolus and then another dedicated for blood. Okay, so you need at least two, or if you can get three, even better. Any other questions? Very good. Okay. So again, the purpose of the NG tube is to decompress. Okay, stop the vomiting. Make sure you maintain its patency though, because when you have bleeding, it's in the stomach. Do you think it will stay like blood consistency?
No.
Because if you now mix blood with acid, what will become of that blood? It will clot. So can it still come out of the little holes of the
No.
NG tube? No, it will clog, right? So now you can't suck anything out. So you need to make sure you flush it with maybe 30 ml every now and then, just to make sure it's still working. Okay, because you can see whether it's sucking anything or not. Yes, ma'am.
Yeah, inside.
It's not really related. No. Okay, perforation and penetration. Perforation is, I mentioned earlier, there's now a hole, right? Meaning the ulcer got so worse that it now went through the middle, and then the outer layer of the GI tract, of the stomach or the duodenum. Now there's a hole. So now you got fecal material coming out into the peritoneum. You have food material coming out as well. So is that dangerous?
Yeah.
Yes, that is high risk for peritonitis, because remember, the peritoneum is sterile. Is our food sterile? Is fecal material sterile? No. Okay. So this is now an abdominal emergency, and therefore will require emergency surgery. Otherwise, the patient will. Do we wait for peritonitis and then sepsis?
No.
No. So again, this serious complication can result in sepsis, and then we already discussed sepsis and septic shock. We know how high the mortality is. So here are manifestations. So patients admitted for a bleeding or perforated gastric ulcer or duodenal ulcer, for instance, you watch the patient for signs of perforation. These are your manifestations. Okay. And then peritonitis will follow. What are signs and symptoms of peritonitis? Abdominal pain, and then what will happen to the focal area?
Swelling.
You will feel rigid, right? Okay, so very rigid, board-like, like this. Okay, that hard. So again, NG tube will be inserted. So whether the patient's bleeding or you have peritonitis or perforation, NG tube. What's the purpose of the NG tube again? To empty the stomach. Okay, because when it's an automatic response, injuries like this will trigger sympathetic stimulation. It will stop peristalsis. You need to insert an NG tube. And usually after the event, because of the injury to the GI tract, there will be ileus. What is ileus? Absence of peristalsis. So we have to wait until this resolves. This will resolve on its own. Okay, there's really no treatment for paralytic ileus, meaning this is just a response by the body to an injury to the GI tract. It will just stop bowel movements. Okay, peristalsis will stop. It will resume. We don't know when though. So until then, the patient will need an NG tube. Okay. So same thing also. So is an NG tube only used during bleeding, perforation, or peritonitis? When is an NG tube also needed? So what are other conditions that will stop peristalsis? What about after abdominal surgery? Yes, especially open abdominal surgery. Laparoscopic, not so much, but open abdominal surgery, is that a major injury to the GI tract? Yes, that will stop peristalsis. Okay, because if it's the same thing as you and me. If somebody beats you, okay, so let's say I have 4 of my homies outside, and then Nicolette comes out. I tell him, hey, she's been giving me the evil look. Okay, Can you take care of that? Then they beat her up to a pulp. You think she will get up and walk home? No, she'll be down for a while, right? So same thing. Any injury to the GI tract will cause it to rest. It will stop. Okay, hey, I don't want to feel like moving any bowels today. Yeah, I'll take. It'll go to sleep. Okay, it's natural reaction to an injury. So therefore, there will be ileus. We don't know for how long. It will eventually return. We do have drugs that will promote um, peristalsis, like metoclopramide, for instance. That's a antiemetic drug. We use that for nausea, vomiting. But how the drug works is it increases peristaltic activity. So that drug may be given to promote peristalsis.
Section is an example of
Yes, C-section can also cause hypoperistalsis, but ileus in that particular procedure is not really common, but it's possible. Yes, it can cause ileus. Here's another complication, gastric outlet obstruction. So this one also will require an NG tube, because gastric outlet obstruction meaning, is there anything moving? No, so you need an NG tube as well. So here, in treating gastric outlet obstruction, NG tube again. So when do we need an NG tube? Whenever there is no peristalsis, basically. Could be caused by bleeding, trauma, perforation, peritonitis, or even surgery. Okay, so any GI trauma.
how do you check when there's check if,
How do you know you have peristalsis? How do you know your bowels are moving? You just assume that they're moving? So how do you know they're moving or not?
See, stop,
This is the patient though. So how do you assess?
touch.
Okay. All right. You listen, right? You listen for bowel sounds. Is there anything moving? Okay. Did the patient pass gas? Yes. If gas came out, it's moving. Okay. Because gas doesn't come out by gravity. Gas has to be propelled. Okay. There has to be peristalsis for gas to come out. For anything to come out of your rectum. Yeah. Okay. So did I answer your question? Okay. All right. So let's go now to drug therapy. Now, the drugs we will also use, I mentioned the metoclopramide, right? Will this patient also need PPIs, proton pump inhibitors, when they're having GI bleeding? Yes. Okay, so give PPIs, and also, now this is a dirty organ, correct? Inside a sterile peritoneum. Could there be infection here? Yes. So what antibiotic will be given? Metronidazole. Okay, so expect also metronidazole, one of the antibiotics we use for treating H. pylori. Okay, so metronidazole is a very common GI antibiotic. It's very good for GI infections. Okay, brand name Flagyl. Maybe you've heard about that. Maybe you've taken Flagyl before. Okay, so it's metronidazole. Okay, 500 milligrams. Can be every 8 hours or every 6 hours. Plus PPIs will actually prevent rebleeding. Meaning, when you cut yourself, will it bleed forever? Why? Why not?
Because you put pressure, the blood on the side.
Even if I don't put pressure, will it bleed? Will I bleed to death if I don't put pressure? No. So because we have natural clotting cascade, right? Yeah, we clot. Yeah. So eventually that bleeding peptic ulcer, will it bleed forever? No, because we have again clotting cascade, it will stop the bleeding. Okay. Because the bleeding really is caused by a broken blood vessel, correct? Because now blood vessels were exposed to acid, then the acid corroded the blood vessel, started to bleed, but our body will eventually stop that bleeding. Once it stops though, the and then we expose it again to more acid. So what will happen? It will bleed again. So therefore, what's the purpose of the PPI? To prevent rebleeding. You understand? Okay, so your next patient will have a peptic ulcer. All right, so we will have these orders. Okay, so you will be giving what? This is the GI bleed patient. They have a peptic ulcer. So what do you expect to give first? Bleeding actively. What's the first thing? Come on, we did shock. What's the first thing? Okay, IV fluids, then
Mhm.
blood transfusion, and then what drugs will be given?
Mhm.
Okay, we may give metronidazole, but is that your priority? What's the priority again? We just concluded it. How do we keep it from bleeding again? PPI, okay? PPI, and then,
Those two receptacle.
well, it's either or. You can't give both, okay? So it's either H2 receptor blockers twice a day or PPI, okay? Because basically they work the same, okay? So you can't give two of the same
Professor.
drug. Yes.
Could you repeat the order for me, please?
Who wants to answer this question?
Blood. Sure. Blood transfusion.
Yeah, that's correct.
Mhm. PPI or H2 receptacle.
All right, are we clear? Any questions on GI bleed patient from a PPI? I mean, from a peptic ulcer, sorry. Okay, very good.